Good afternoon. Thank you for joining Alabama Medicaid's ACHN webinar on cost effectiveness. My name is Melanie Cleveland, and I'm the Director of Communications here at Alabama Medicaid. The purpose of today's webinar is to provide an overview of the new ACHN changes effective October the 1st of 2024. I would like to introduce our speaker today. Courtney Hanson is the Managing Director of the Institute of Data and Analytics at the University of Alabama. As we get started, I have some housekeeping items to go over. All participants have been placed on mute as you join the meeting. Please do not unmute your phone or your microphone during the presentation to avoid disrupting the presenter. To record your attendance in today's meeting, please type your name and the organization that you represent in the chat box if you've joined through WebEx. If you've joined by phone, please email your attendance to achn@medicaid.alabama.gov. If you have questions, you may email them to that same address, achn@medicaid.alabama.gov. The program area will review questions submitted and post responses on the ACHN provider's webpage. Previously submitted questions will be posted next week on the agency website at www.medicaid.alabama.gov. To navigate, you select the ACHN tab, and then you select ACHN providers from the drop-down menu. Today's webinar is being recorded. It will be posted on the Alabama Medicaid website under the ACHN providers tab. And I will now turn it over to Courtney for the presentation.
Thank you, Melanie. All right, so today's webinar, we have a few objectives. We're going to review the attribution process. We'll introduce the cost effectiveness bonus, and then we'll discuss some of the components of the bonus calculations, and then we'll go over the cost effectiveness bonus process. All right, to start off with our attribution review, I first wanted to remind everybody that there is a webinar posted to the ACHN website that explains the attribution process in greater detail. The attribution is the process that will be used to associate a Medicaid recipient to the PCP group that provides primary care to that recipient. Under the ACHN program, Medicaid recipients will be attributed to PCP groups based on historical claims data utilization. Therefore, PCPs are encouraged to continue seeing their patients as medically necessary on a consistent basis to increase the likelihood of attribution. Attribution is a critical factor in determining the distribution of bonus payments amongst the eligible ACHN providers. All right, so the key steps in attribution are first that the Medicaid recipients have met the criteria for the ACHN program for 3 out of the previous 24 months. These 3 months do not have to be continuous. The process then looks at the previous 2-year history of face-to-face provider visits. Both preventative visits and regular office visits are scored. Preventative visits receive a higher point value, and then recent visits are scored higher than older visits. PCP visits will receive a higher point value than specialist visits. And then we also add the previous 12-month history of filled prescriptions for chronic care conditions to the score. The process is that on a quarterly basis, the Medicaid agency determines attribution for each Medicaid recipient under the ACHN program. So point values for face-to-face visits are assigned to the individual provider. Those individual provider scores will then be combined to form the PCP group's total score for each patient. The PCP group with the highest number of points will have that Medicaid recipient attributed to that PCP group. If a specialist group has the highest number of points, then the specialist group will be attributed to the Medicaid recipient. Another review of the PCP payment structure under the ACHN can be seen on the screen now. As a reminder, the payment structure includes an enhanced fee-for-service rate and a quarterly bonus pool. The bonus pool consists of bonuses for quality measures, PCMH recognition, and cost effectiveness, which is the subject of today's webinar. And as you can see, that bonus pool is impacted by attribution. Now, also a review of the bonus payment timeline, starting with October 2024, when the new program starts. You'll note that the calculated cost effectiveness bonus payments will be paid at the beginning of the new ACHN contract, October 2024. The bonus pool for the ACHN program is $15 million annually to fund these 3 bonus payments. 45% of the total bonus pool will be paid for cost effectiveness. These bonus payments that are made on a quarterly basis. Each quarter, $100,000 is reserved from the bonus pool in order to offset bonus payment issues. That reserve fund is then distributed at the end of the fiscal year according to the previous earnings. Right, so with the cost effectiveness bonus, our guiding principles were to have consistency with the ACHN's principles of paying for activity with a focus on preventative care and health outcomes. We also want to acknowledge that risk levels will vary across practice. In other words, we are trying to account for sicker recipients and acknowledging that they are also more expensive recipients. We are adhering to commonly accepted, validated risk adjustment methodologies, and we're evaluating the activities at a group level. To start with an overview, the cost effectiveness bonus is where all participating PCP groups are eligible for performance payment if the PCP group meets or exceeds the cost effectiveness criteria established by Medicaid. Medicaid uses Milliman Advanced Risk Adjusters, or also called MARA, and for the rest of the presentation, we'll be saying MARA, software to assess the cost risks of the ACHN population and then apply a customized algorithm to calculate a cost effectiveness score for each participating PCP group. To qualify for the cost effectiveness bonus, PCP groups must have a score less than 1. Cost effectiveness scores are made up of 1, the overall risk of a PCP group's attributed recipients, 2, the overall per member per month, or PMPM, cost of the PCP group's attributed recipients, and then the overall PMPM cost of the statewide attributed ACHN population. So the actual PMPM costs are compared to a risk-adjusted expected PMPM cost to determine the PCP group score. So let's now break down some of the components of the group's cost effectiveness scores. So starting with the MARA risk scores. Risk scores in general are standardized metrics that are used to evaluate a member's previous health experience and/or to predict health outcomes. Again, like I said, Medicaid utilizes software developed by MARA for these calculations. MARA's software uses several statistical models in order to take the information to create a single score. Concurrent risk scores are used in these cost effectiveness calculations, and the concurrent risk scores are normalized to the ACHN attributed population. Also, as a reminder, other types of risk scores are used elsewhere in the ACHN program. So it's important to note that these concurrent risk scores are used only for the cost effectiveness calculation, and which these risk scores are different than risk scores you may see elsewhere. So what goes into the calculation of the risk score? You'll note in this chart that there are 3 different types of information that is put into the Milliman Advanced Risk Adjusters model software. We have member demographic information, claim information, and prescription information. All claim information and prescription information is on a claim level. All of these inputs are put into the software and they output one total score. I want to highlight a few boxes that we have orange around, which is the diagnosis code, the diagnosis sequence, and the procedure code. Through our analysis, we have found that these 3 are the items that have that give the greatest insight and the greater impact on the risk of the patient. The input file has space for 40 diagnosis codes. We expanded that through this process, and so I know that that is way beyond what any number of codes that are going to be on any one claim, but I wanted to make sure that I emphasized that we are pulling in as many diagnosis codes as we can. Finally, I just want to point out at the top left that all input information pertains to the 12-month period prior to a 3-month rollout. And I want to point this out because I want to say that we are using the same time frame for the risk scores that we are using for the cost calculations. So like I said, concurrent risk scores assess members' health risks based on the previous year's claims information, including cost and diagnosis codes, and predict the member cost for that same period. Claims information includes costs generated by inpatient, outpatient, ER, physician, and other categories. Just to highlight a few of the other categories would be things like durable medical equipment, lab, radiology, that sort of thing. And so then the average concurrent risk scores are calculated for a PCP group's attributed members, and then are considered that's considered the PCP's risk score. The next component of cost effectiveness that we're going to review are the members' costs. Costs are calculated on a per member per month basis at both the provider level and the state level. When we say state level, we mean the attributed ACHN member population. Member costs include 12 months of claims prior to a 3-month claim runout period. So for example, the October 2024 cost effectiveness member cost calculations will include claims from July 1st, 2023 through June 30th, 2024. Exclusions from these cost calculations are any Medicaid member with $250,000 or worth of claims or more in the 12 months. Certain program costs, so network entity, case management, some of the bonus payments are not included. And then also certain costs that are paid in a way that are unique to the Alabama Medicaid agency. So these costs are removed because the risk scoring methodology will not adequately account for these costs. Which I also want to take a moment when we talk about these costs and talk about some of these changes is to point out the changes that we are making from the previous, that we have made along the way while we have been continually improving this process for this bonus. And I just want to acknowledge that this has been because of a collaborative effort between the agency and providers. So some of the changes in methodology has been that we've removed certain costs that are unique to a way that Medicaid pays for services. We have removed recipients that have costs totaling $250,000 or more. And then we also changed the bonus threshold from the median of all providers in the ACHN program to the cutoff just being 1. All right, so now that we've discussed the details, let's put together the process. So we'll have an illustrative example, and so before I start showing all those charts, I'm going to make a reminder that this will be posted to the website where you can watch it over and over again. But so for each PCP group, we're going to compare a 12-month per member per month to a risk-adjusted expected per member per month. So just wanted to point out, if you can look at this equation and keep it in your mind, that will be very helpful. So the cost effectiveness calculation includes a PMPM calculation for the statewide attributed population. And then bonus payments are paid to PCP groups with a cost effectiveness score below 1. And I want to highlight here that I, in this slide, put 1.0000. And I did that to denote and highlight that we do calculate out to the 4th decimal point. Okay. So let's walk through this process that we just that we just talked through with our hypothetical PCP group that we know and love, Gallagher Family Practice. So in our example, we're going to start by assuming that the statewide attributed ACHN members is 500,000 members. This process, the goal of this process is to distribute the quarterly cost effectiveness bonus payment pool, which is $1,642,500. This process has, as we walk through this, we'll have 3 steps. We'll look at member attribution, then the cost effectiveness scoring, and then the bonus distribution. To start with member attribution, we'll note in step A that Gallagher Family Practice has 6,300 members attributed to them. So moving from left to right, we'll go to box B, and we'll see that we're going to calculate the distribution rate of the attributed members by dividing the members attributed to Gallagher Family Practice, which is 6,300, by the total attributed members, which is 500,000. And so we have that distribution rate is 1.26%. And so during this illustrative example, which is made up of fake data, we will be going back and forth between the flow chart and this chart. And this is to help you see how Gallagher Family Practice sits within the statewide ACHN population. And so you can see that in our example, Gallagher actually has the smallest member distribution in column A and column B. Okay, so now for the cost effectiveness scoring process, we'll start in box C in the upper right corner. And we start by calculating the PCP group's PMPM. Gallagher Family Practice's PMPM is $221. Right below that box in the call-out box, which is D, the statewide PMPM has also been calculated. And that's the statewide PMPM amongst those 500,000 providers. That PMPM is $269. Moving over to box E, we see that we've also calculated Gallagher Family Practice's group risk score of 0.89. Using the component of the risk score and the statewide PMPM, we calculate the expected PMPM of Gallagher Family Practice, which is $239. We now have all components of the cost effectiveness score. And so to calculate Gallagher Family Practice's cost effectiveness score, we're going to divide the group PMPM by the expected PMPM to get a cost effectiveness score of 0.92. So moving then further to the left in our decision point, which is noted as H, we have whether we need to determine whether or not our cost effectiveness score is below the threshold. And Gallagher Family Practice's cost effectiveness score is in fact below the threshold. So we move on to the diamond that is labeled I that says, yes, we are eligible for the cost effectiveness bonus because our score is below 1. So continuing down, our last part of that is to determine the distribution rate of the attributed members now that we've made the decision of who is below 1 and who will receive the bonus, who is below 1 and will receive the bonus, and who will be removed. So once we eliminate the attributed members that are in groups that will not receive the cost effectiveness score, we have 307,342 members in the statewide attributed member population. So our new distribution rate for Gallagher Family Practice is 2.05%. So when we move to the new chart, we can again compare Gallagher Family Practice to the statewide ACHN population. So we can start in column G to see everybody's cost effectiveness scores. All of the information to the left of this column shows all of the different various components that were used in order to calculate the cost effectiveness score. As we move to the right, we determine which practices are below the threshold and will receive the cost effectiveness bonus. Once we determine if they will receive a bonus, we then add their attribution to column J if they will receive the bonus, and we remove them if they will not. And you'll see at the bottom, that is where we get 307,342 as the new statewide population for the distribution of the bonus. And then we roll to the right in column K to see what that new distribution percentage is. And then to calculate the bonus distribution, we take the bonus distribution rate for each provider, which again, for Gallagher Family Practice is 2.05%. We multiply that rate by the quarterly pool amount, which was about 1.6 million. And then we get that Gallagher Family Practices bonus amount will be $33,671 for this quarter. And again, you can see where we've multiplied that in the final column of the bonus distribution amount. Thank you very much for sticking with me through that illustrative example. Again, want to remind you, this will be posted so that we can move through it again and again.
Thank you, Courtney. Please remember to record your attendance today by typing your name and the organization that you represent in the chat box. You can also email your attendance to achn@medicaid.alabama.gov. You can continue to submit questions by email to that same email address, and responses will be posted during the first week of October. Thank you again for your attendance, and we hope you have a great afternoon.